Because it's World Spine Day, I want to take a minute to discuss what the spine is. The spine is a very complex part of the body and can be very frustrating for patients and doctors alike. It has so many different moving parts, and if you think about any other type of pain, knee pain, it's a fairly simple joint. There's one motion. The knee has to go in and out. The knee can be replaced. There's no spine replacement that we can do. I often joke with my patients, this might be easier to actually get your head put on some other spine than fix your whole spine because of all the moving parts. So the spine does a lot of different things, including providing support. It protects the nerves so that your extremities can function. A lot of those nerves people think about for the arm, for your head, for your legs, but also the nerves for your internal organs, for your GI system. It allows you to move in so many different ways, and it absorbs incredibly complex loads. When talking about the spine, I think it's important to recognize that it moves together. There's a disc in between two bones, and then on the back of the spine, there's facet joints. If one part of the spine is affected, it often translates to other issues with the spine. And that's what makes spine care so difficult, is that not only are we trying to fix a nerve pain shooting down the leg, but there may be some back pain associated with some facet arthritis, or back pain associated with disc bulging. Or in the worst cases, the nerve doesn't work at all and the whole segment is not functioning. I took this little video on my iPhone with one of my apps, and it's a perfect skeleton. We're flipping the skeleton around and looking at all the structures. And I want to highlight that there's many different moving parts, including this multifidi chain that we'll talk about later. We have the psoas muscles in the front. And as you keep adding layers on, you can see that not only is the spine made up of the functional unit, but it's also made up of all the supporting muscles. And if there's any violation of those muscles, let's say an abdominal surgery, a traumatic injury to one part of the muscle chain, then it can cause a lot of issues and a lot of further degenerative problems. So the question is why does spinal pain exist? And the answer is degeneration or trauma. And the sad fact is that 80% of people in this room will have back pain, sciatica, pain shooting down the arm, all the above, or a little part of that at some point in their life. So this affects everybody. And everybody's spine will degenerate. It's just a natural phenomenon. We think that direct toxins can accelerate that. So smoking can decrease blood flow everywhere, including the spine. We have very little blood flow to the discs. And if you smoke or do anything, trauma, take in toxins to your body, that can affect the blood flow and it can start the degenerative process. I like this slide because it demonstrates different grades of disc. And I like to look at this to tell exactly what degenerative grade patients are at. So this is called modified Fearman scales. And basically it brings out grade 1 through grade 8. Grade 1 through 3, the disc has normal height. So there's a lot of cushion there. But you can see from going from grade 1 to 2 to 3 that the disc doesn't look as white. The signal is not as prominent. Grade 4, 4 through 8, the disc height starts to be affected and the degenerative pathway progresses. So important to realize that if the disc collapses or the disc loses height, it also puts pressure on the nerves. This slide really illustrates that philosophy or that thought that if you affect one part of the spine, you're likely affecting the other parts. So this is called the 3-column model. In the front, you have the disc and the bone. In the middle, that yellow area, you have where the nerves live and you have more ligaments. And in the back, you have the facets that can cause back pain, usually due to arthritis or slipping. Many different structures support these, and they all have different nerves. which is important as an interventional pain doctor. They're all areas that we can target to try to alleviate pain. Going back to what Dr. Bob was saying, I have a little bit more statistics, but back pain is a really big problem in the US in terms of dollars and time away from work. It's estimated $86 billion in terms of medical care, surgeries, treatments, and another almost $100 million worth of people not being able to work. So lost wages, disability, affecting a lot of businesses and people's lives. The main point of this talk, now that the introduction is complete, is I want to talk about two new exciting treatments that we have to offer in terms of really regenerating how the spine moves and potentially regenerating discs in the spine. The first is restorative neurostimulation. We use neurostimulation a lot in my practice to basically quiet nerves that are over sending pain signals. This is more of a neurostimulator that actually recreates the mind-body connection of the multifidi muscles in the back. And then the second is orthobiologics, which is a fancy way of saying regenerative medicine. Sometimes people know this as platelet-rich plasma or stem cells. I think part of me is the most excited about restorative neurostimulation because it's one of those things that as a pain doctor, I can say we're making a really long impact in someone's life. A lot of our treatments today are currently steroid injections or nerve burns that offer short to medium term relief. And that's very frustrating for a patient to have a treatment and then it works for a while and then have to come back for another treatment for a maintenance phase. This is one of the things that actually strengthens the core, and it does it for a long duration. So we have really good evidence for this type of therapy. What it is basically is an implantable device with two leads that get placed on the multifidi muscles and they activate the medial branch nerve. There's a 12-month protocol with two 30-minute sessions of basically physical therapy in the back a day. After 3 to 6 months, we see postural restoration, and after another 3 to 6 months, we see pain relief. This is one of the few implantable devices that actually are taken out of the body because it's a success. Why do we think that this works? We do have a really nice randomized controlled trial demonstrating that it works, but we think that there's a pathway from the back muscles that support the spine going all the way to the brain. And if anybody goes through back problems, gets injured and doesn't rehab fast enough, we think those multifidi muscles shut down. They just stop working. And a lot of times patients will experience severe cramping in the back. And that's likely the paraspinal muscles, the big back muscles behind these delicate multifidi muscles that's actually working overtime because the multifidis are not. These multifidi muscles act as a spring. And when they're wound up really tight, they protect the spine. They take spinal pain away. When they go away, they lead to or accelerate degenerative changes. So on these MRI clips, we see axial cuts. So we're cutting the human straight across. And what we see on the top of the picture is the disc and bone segment. We see the nerves in the middle, and we see the facet joints in the back. And this is a cut through what would be the T-bone steak. And I talk to patients about this cut all the time in the office, and we look at the pictures. The part of the T-bone steak that's closest to the bone is known as the multifidi. And you can see going from normal multifidi muscles to mild atrophy that there's more white there. And that's basically fatty replacement of the muscle. Moderate, there's more loss, and then severe, there's almost a white out of muscle. The muscle is not there anymore. So those muscles aren't there, the spring is not wound up tight, and spinal degeneration can happen quicker. This is a picture of what the implant looks like under X-ray vision. There's no real test for this sort of a pain besides what the patient tells me. And oftentimes I hear, my back is weak. I can't stand for more than 5 or 10 minutes. I can't walk for more than 5 or 10 minutes. And I need to sit down. My back hurts and it's weak. And then there's 2 specific physical exam maneuvers that we utilize every day called the PIT test and the multifidi lift test. And I demonstrate that to patients and see if it's positive. If that's the case and there's no other spinal problems like sciatica or severe disc pain, then they're a candidate for this procedure. There's 2 little incisions with 2 wires threaded out on the multifidi, and then a battery pack that goes there. These are put in 20 to 30 minutes, and they're taken out in about 10 minutes. What we have in terms of data for why we think that this works, we have a 5-year level 1 randomized controlled trial following 200 patients out. We also have functional MRI imaging where patients use the device, they sit or lay down and they turn it on and they feel an intense contraction in the back. After a few months, they have to have that signal turned down because the muscles are working much better. And they've done functional MRI imaging that shows increased uptake of those muscles for up to 2 hours after each use of the device. This therapy has been FDA approved since 2021, and it is, like I said, one of the few therapies that patients actually have the device taken out because it works. What these graphs explain is pain scores. So on average, 7 to 7.5, dropping to 2 to 3, and then sustained for 5 years. Second graph is called Oswestry Disability Index, asking questions, how long can I stand? How long can I sit? How long can I travel? How many hours can I sleep before my pain wakes me up? And those scores are all decreased. On average, the patients had moderate to severe disability, and they dropped 1 to 2 categories, so mild to moderate. And then the last graph is the quality of life. And so you see sustained and marked improvement in quality of life over a 5-year period. Some of these lines end early, and that's because the device was taken out. So I did the first implant of this therapy 2 Aprils ago. My patient was injured with military service. He was in his 30 to 40. We saw him back at the 1-year anniversary. He had no pain. I said, we can take the device out. We talked about scheduling that. He's a mechanic. He's down on his arms and crawling under things and fixing things. And he called back to the clinic and said, I don't want to take it out yet because I had a little twinge of pain and I used the device once and now I'm pain-free again. I just want to keep it for a little bit longer, which I can totally relate to. For the second half of the talk, I'd love to shift to orthobiologics, also known as stem cells. So as Aristotle, over 2,000 years ago, in his History of Animals book, noticed that these lizards can regrow their tails. Wouldn't that be nice if we could just regrow a body part or regenerate the spine? There's been a lot of talk about this and even postulation that a new branch of medicine will come out shortly. In the 90s, they talked about it in terms of actually fixing failing organ systems or fixing painful areas of the body. And over the last 10 years, we've seen an explosion of platelet-rich plasma, bone marrow aspirate, other types of cellular therapies to help regenerate. In terms of orthobiologics, we have basically a cascade of options. We have things that are commonly used in the US, like platelet-rich plasma, platelet lysate, and bone marrow concentration injections. We also have access to microfragmented adipose tissue, or MFAT. And then we have some things that have been used that are currently illegal to do in the United States in terms of amniotic fluid injections, exosomes, which are proteins from stem cells. And in Europe, they've been actually taking cells out of the body, stimulating those cells to make more factors, and then placing them back in. In the US, we can't currently do that, so I'd like to focus on the top 2, platelet-rich plasma and BMAC. Platelet-rich plasma is also known as PRP. it's been a pretty amazing treatment and an amazing option that I can offer patients. Why we think platelet-rich plasma works is because platelets are one of the first cells when we get injured to actually get to the site of injury. Platelets get to, let's say you cut a blood vessel in your arm. Platelets are the first cells that do something when they get there. They initiate a clot. The body starts throwing down fibrin, which is little strands of basically glue. All these other cell factors get attracted, and then we find that other cells come to the area because of cellular signaling. Because that happens, the healing process starts. So what PRP is essentially is your own blood product. We take out the red blood cells and we take out the plasma, and we have a very high concentrated cell fraction of platelets. We're talking 5 billion platelets after drawing 60 cc's of blood, when normally in 1 cc of blood, we have a few 100,000. Platelets can be accompanied with white cells, or we can spin the white cells out. And what the white cells do is they actually allow us to create more of an inflammatory response. So the white blood cells that fight infections in your body, they actually cause more inflammation. And for certain types of injury, like ligament problems, we can use more white cells. For joints or for other issues that we don't want to have inflammation, like in the epidural space, we take out the white cells. This simply consists of drawing blood, about 60 cc's, spinning it down to about 6 cc's, and then putting it where we think the pain is coming from. This has been used for about 20 years in the United States and even longer in Europe. And I would say over the last 10 years, there's been much more clinics offering this as a viable option. This picture was actually done at my clinic. That's plasma, and the platelets are the very bottom level where that glass meets the actual yellow plasma. They're all concentrated down there, and you can spin the platelets out and see them come back into the plasma, or you can just take the platelets out. There are certain things that don't allow platelets to function, which are simple NSAIDs, ibuprofen, anti-aspirin products, Excedrin, things like that. And for this treatment, we want the platelets to be working fully, so we typically have patients stop NSAIDs. There's also been more data, a study published in the Journal of Nature that shows we're probably taking too much in terms of ibuprofen as a general population, meaning that we want to have inflammation when we have pain at some points because inflammation is healing. There's numerous mechanisms of action for PRP, why PRP works. And we think it's because of all of the attraction of healing cells to the body. But it's been shown effective in numerous studies, including bone issues, tendon issues, muscle, ligaments, joints, and discs. I would say by far, the most evidence we have for this therapy is with knee arthritis. I want to talk specifically about discs because it's World Spine Day, of course. We have some studies, but the studies are very limited. And I was able to do a literature search in preparation for this talk. When we talk about evidence, there's different levels. Level 1 meaning the highest level of evidence. Patients were randomized to that treatment versus normal care. Level 2, which is we're going to have patients come in and they're all going to get the treatment. We're going to follow them out over a period of time. And then level 3, which are just simple case reports where a doctor says, I did 10 of these and this is what my results were. You can see we have 2 studies of level 1, we have 2 of level 2, and 2 to 4 of level 3. In all of these studies, we see 60 to 70% improvement of disc pain at 12 months. And the disc is notoriously hard to actually help and treat with interventional pain treatments. We don't see a change in terms of the disc height, and we don't see a change in terms of the disc signal, if you remember my slide where we're talking about the grades of discs. Degeneration is a normal process. Everybody will have spinal degeneration sitting in this room. And I think patients would like their discs to be healthier and to regenerate, but most patients just want to do things. They want to be able to walk and stand and bend and twist. These studies support that for a problem that's very hard to solve otherwise. One of the issues with most of the studies that we find is that no one uses the same machine to spin the platelets down. No one's telling how many platelets you're getting with each count. No one has specific protocols afterwards. So I just injected your disc with PRP. What are you supposed to do? No one had a very standardized way of collecting this. Moving on to bone marrow aspirate. Bone marrow aspirate is something that we utilize when we want more of a healing effect. So bone marrow has cells in it, mesenchymal stem cells, that we can take from your body and spin those down. The stem cells have a lot more activity, but it is much more invasive of a procedure. It requires me using a mallet, a small hammer, and then tapping into your bone marrow at the iliac crest and then taking out that substance. Then we do the spin down, and it's identical to PRP at that point in terms of the process. Looking at bone marrow aspirate injections in the disc, the evidence is again very scant, level 1, 2, 3 trials, but the evidence is better for pain scores. And they do show some signal improvement on the MRI. In all of these studies, no one had increase in disc height, but they had improvement in signal, which is very promising. Again, no one used the same machine, no one standardized any process for afterwards care. In summary, platelet-rich plasma versus bone marrow injection for disc, there's definite positive studies. PRP is more functional improvement in terms of disc pain. Bone marrow has the potential to actually help change the signal in the disc. It also is more invasive, but hopefully would lead to longer duration of action. One of the problems that I found with a lot of these studies were that they were looking at disc pain only. And we talk about the functional spinal unit a few slides ago. The spine is not just a disc with a bone. It's the ligaments, it's the joint, it's the muscles. So how we approach this currently in a lot of practices is we focus on the multifidi muscles with regenerative cells. We put that in the disc, we put it in the facets, we put it in the ligaments, and we try to treat the whole unit to get the best results possible. I think a lot of studies are moving closer to this, not just saying that disc in isolation is the problem. I am very excited for my future in terms of for my patients and my practice. I feel like interventional pain is growing leaps and bounds. We have a true evidence problem because a lot of these therapies are new and novel, but the evidence keeps growing every day, and hopefully in the future we'll have very good evidence for really good treatments that last a long time.